Hello and welcome, everyone. My name is Kristen Talbot. I'm the Director of Programs for MAVEN Project. Thank you all for joining us today, and our friends at Mariposa Community Health Center for hosting today's session, Pediatric Headaches with Dr. Lynn Kerr. Dr. Kerr is a pediatric neurologist in Salt Lake City and Professor Emeritus at the University of Utah. And we're so very lucky to have her as one of our MAVEN Project speakers. So Dr. Kerr, when you're ready, please begin.
Okay, thank you, Kristen. Good morning. I'm going to be talking about headaches in children today, and I really like giving this talk because I started out about 20 years ago just kind of not wanting to see patients with headache because can be really difficult. And then I ended up getting my headache certification, and we started a headache clinic in our children's hospital, and we included behavioral health, and it got a lot easier, and it got to be kind of fun. Before I start, no disclosures. There's an hour of CME. So my objectives are to define the major headache types in children and adolescents, to evaluate effective diagnostic workups by type and to plan effective treatments, both acute and preventive. And one of the secrets of headache is to do appropriate follow-up for children and adolescents, so we'll talk about that as well. So this is a picture that a young man, about 12 or 13, drew of his migraines, just to give you an idea of how bad the headaches are perceived, how much they hurt, and how serious they should be taken. Why are we going to talk about headaches? Headaches is one of the top 5 health problems in children. It's the second most common diagnosis in the Pediatric Neurology outpatient clinic after seizures/epilepsy. And as I said before, it can be a frustrating diagnosis to work with. It has a prevalence of 62% of headaches in children. They're all primary headache types combined: migraine, migraine with aura, and tension. So a majority of children have headaches. Females have more headaches than males in children, but in adults, females have a lot more headaches than males. About 11% of migraine overall, majority of migraine without aura in children, about 17% for tension headaches, and these might not hit the pediatric office as much, and then that's just a reference for that, updated to 2023. Headache prevalence, many other studies in many countries show similar prevalence. I think that's an interesting statistic because I think providers will sometimes feel like, oh my gosh, these are spoiled kids and they're worrying about their headaches. Not you guys personally, of course, but headaches become a lot more frequent over adolescence. And as I said before, headache prevalence is similar in boys and girls before puberty, but after adolescence, girls have 1.5 more and 1.7 times more migraines. So these are patients with headache, but the slide is to talk about having patients with headache. So to get the child on the left to look more like the child on the right. So there are many classifications of headache. The first one I'm going to talk about is primary versus secondary. Primary headaches mean it's just a headache. That's not to belittle the headache, but just to say it's a headache, it doesn't have any cause. Parents are often looking for cause. Why is my child having headaches? Well, headaches are the cause, except in secondary headaches, which are caused by things like brain tumors, which is every parent's nightmare, bleeds, vitamin problems, etc. We look at the characteristics of headache to classify into primary and secondary, and we'll talk about how to think about this some more. But individuals who are prone to migraine are more likely to have migraine-type headaches, even due to secondary causes. So you can't just go by characteristics. So even if a 12-year-old girl who has a history of migraine also had a brain tumor, they might look like migraines at first. So then let's talk about the time courses of headache. So in purple are acute recurrent headaches. These are usually headaches that you don't have to worry about. So the person has no headache at baseline. They go ahead and they spike to have this headache. They get all the way better. A month later, they spike again. The headaches that are very worrisome in terms of being secondary headaches are the acute headache in black and the chronic progressive headache in red. Both of those signal that there might be something more underlying the headaches. Usually the chronic non-progressive headaches, the ones in green, where the person has a headache almost every day, but it's not getting worse with spikes of bad headache, is also not something real concerning in terms of having an underlying cause, but of course concerning in terms of you have to get that treated. Red flags for headache that I look at are very young children. So if it's a 2.5-year-old that keeps on holding their head, that worries me. New onset headache that comes and then just stays there or keeps on getting worse is worrisome. Abrupt onset. Progressive symptoms. So this was that red line that's going up, showing that the headaches are getting worse and worse. Any kind of abnormal neurologic signs, so problems with eye movements, problems with weakness or numbness is worrisome. Headaches with exertion can be worrisome. Usually they turn out not to be, but that is a red flag for me. Changing with head position makes me worry that there is a mass in the skull. Changing with Valsalva maneuver. Headache and vomiting in the morning can be a sign. So you're going from lying down to sitting up or standing up, and that can be a sign of a brain tumor. And personality change is also a red flag. So let's look at a case study, a kind of typical 14-year-old girl with a severe headache. She's normal in between, but gets headaches 1 to 2 times a month. She has a history of motion sickness when she was younger. She goes like this when you ask her where it hurts, so bilateral across the forehead. She describes the headache as throbbing. And all she wants to do is lie down in a dark room and go to sleep. And often if she does that, she wakes up feeling better. There's also a family history of migraines in her mom and her aunt. The history is she's had these headaches for several years, but they're staying about the same. She has nausea and vomiting with headaches most of the time. Her review of systems is normal, except that she saw her PCP for abdominal pain without any cause, and she does have a history of concussion. On physical exam, her vital signs are normal, including her blood pressure. She's alert and interactive. Her weight is normal, and her general and a complete, but pretty fast neurologic exam is normal. So going back to this time courses, she has the purple line, so normal in between acute recurrent headaches. So now we're going to talk about primary headaches only. So secondary headaches are out of there. And the major types are migraine with and without aura, tension, chronic daily headaches, which can be very difficult to treat. And then there are some more unusual ones that would most likely be referred to a pediatric neurology clinic, trigeminal autonomic cephalgia, stabbing headaches. And they're pretty unusual in children. Migraine complaints, it's usually severe pain. They usually tell you it's pulsating. They last 1 to 72 hours. Although they're unilateral in adults, they're usually bilateral in children, and they're accompanied by vomiting, abdominal pain, photophobia, and then plus or minus aura, which changes the type of headache. So you have to ask about the quality of the headache, tightening, which is often tension, headache, pulsing, throbbing, stabbing, how long it lasts, where is it located, and any associated symptoms such as nausea, vomiting, visual changes, zigzags, or photophobia. There are 2 major subtypes of migraines, migraines with aura and migraines without aura. So I'm going to talk about the adult criteria first, because as I understand it, most people in community clinics see pediatric and adult patients. So migraine without aura in adults is common migraine. And to meet criteria, as put forward by the International Headache Foundation, you have to have at least 5 attacks lasting 4 to 72 hours. They have to be unilateral, pulsating, moderate or severe, aggravated by routine physical activity, and at least one of the following: nausea and or vomiting, and photophobia and photophobia. So those are just the way the criteria are to make the diagnosis. Migraine without aura in children, there are exceptions to those adult criteria. Attacks may last as little as 1 hour. They're commonly bilateral in young children, and you have to infer things like nausea, photophobia, osmophobia from behavior of the child, because often you can't ask like a 5-year-old whether they have photophobia. Migraine with aura is also called classic migraine, and it's only 20% of people with migraines. Often aura or migraine with aura runs in the family, and many people with migraine with aura also have migraines without aura, commonly a mix of those with and without. The migraines with aura tend to be pretty infrequent, sometimes just a few in a lifetime, although usually not quite as rare as that. But they're much less frequent than regular migraine. One important thing about migraine with aura is no motor weakness. So if somebody has weakness in their right arm, I worry more that it's a stroke or a TIA and not just a migraine with aura. Although sensory symptoms such as numbness might make it harder for you to move an arm, so you have to differentiate. Positive examples of aura are flickering lights or spots or lines. You can also have numbness and loss of vision. Typically, the aura comes before the headache or comes all by itself and is not followed by a headache. But again, remember, no motor weakness. Typical aura consists of visual and or sensory and or speech symptoms in that order. It occurs gradually. It doesn't last longer than an hour, and usually a mix of negative features, and everything goes away. If things aren't reversed, if the person doesn't go back to normal, I worry more again about a stroke or a TIA. And then, of course, it has to be associated with the headache fulfilling criteria for migraine. So these are some examples of auras. This is just some scotomas. This is a scintillating scotoma where it looks like you have these little crystals, and these will come. People will finally, they'll kind of know that something's wrong in their vision. Then they'll notice that they have the aura. The aura will often get bigger and then just go away over about an hour. The visual aura is the most common type, although can have sensory disturbances, and then speech disturbances. So not as obvious as in a stroke, but just some problems moving their mouth, mumbling. And again, look for the motor symptoms and think about something else. There are a couple of rare entities called familial hemiplegic migraine or sporadic hemiplegic migraine, and those are diagnoses of exclusion, and you're going to be getting MRIs on people if they have motor problems before you can decide it's one of these kind of headaches. So there's a whole migraine experience. It's not just the headache. There can be a prodrome up to 3 days for the headache, irritability, sensitivity to light. And this is when we think the hypothalamus is activated. Then there's an aura phase, if there is going to be an aura, and that is due to depolarization of the cortex and cortical spreading depression. And then there's a headache pain phase where neurovascular theory shows activation of the hypothalamus thalamus, leading to activation of the trigeminal vascular system, which then leads to pain fibers all around the head and the neck, releasing inflammatory substances. And then there's a postdromal phase. Often people are not back to normal completely after a migraine for up to a couple of days. They've actually been studying lately some of the new GPANTS molecules for migraine headache, and it seems like those help with the prodromal phase as well. And then here's the trigeminal vascular system. I kind of have too many slides today, so I won't go into all that. Evaluation of a child with a primary headache. Look for red flags. Make sure their vital signs and weight and height are okay. Full physical exam, including the neurologic exam, especially paying attention to eye movements, symmetry of movement, coordination of reflexes, and also a fundoscopic exam. A fundoscopic exam is important to do to rule out papilledema. This might be most easily done depending on your comfort with this by sending them to an optometrist or ophthalmologist. Emergency rooms these days also can do a photo of a fundus, of somebody's fundus, and then send that off right away for an ophthalmologist to look at digitally. So if all these things are normal and the headaches don't fit red flags or have an advancing clinical picture, you probably have a migraine. So again, back to those time courses of headache. Then we're going to talk about other tests to do. Offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. And we all don't want to be like this doctor. So evaluation, it's very rare that a child with a headache has an underlying etiology, yet more than 3/4 of the patients in our clinic have had CTs or MRIs before they even visit with us. That's just astounding. It's kind of a waste of money. Neuroimaging findings, many which are just non-specific, like some old scarring or something, not anything to worry about, have been found in only 1.2% of neurologically normal patients in our clinic. So very tiny amount. If you are going to image, don't do CTs in most situations. They often lead to an MRI to get a better picture, and they expose a child to radiation. And leukemia risk and brain cancer goes up with CT exposure. So MRI of any kind of imaging. And then I was kind of astounded when I started doing this, that there are many children and adolescents that have difficulty with MRIs and need sedation. Often lab tests are done, but my question is, what are you looking for? So I tend to not do those unless I have some reason to. TSH would be the one that I would maybe think about the most. So migraine treatment. The first thing to do is start with journaling. Journaling is therapeutic on its own, but it also lets you know on your next visit the pattern of migraine this person has. They should also look for triggers when they write in their journal, association with periods for girls, whether it occurs with sports. And this is one website that has some good apps for migraine tracking. For migraine treatment, there's no magic pill. Hydration is really important, especially where I live, where it's very dry. Daily exercise doesn't have to be a lot. Getting good sleep, which is a problem for adolescents, especially as their bodies want them to go to sleep late and wake up late, and our schools make them start very early. Appropriate weight, thinking about stress and anxiety in their lives, and diet. Do not prescribe narcotics. They tend to make headaches worse over time. And then this is just about water drinking. How many times must I remind you? 8 glasses a day. And that is what we try to do, is 8 glasses. So migraine treatment is divided into acute care or rescue, what somebody takes for a standard type migraine, and preventive, medication someone takes every day to decrease headache frequency and intensity. So acute treatment in general, it needs to be taken as soon as possible after the start of the headache. So if your headache starts and you don't have any medication with you, or you're at school and you have to have the migraine for 3 hours, it's not going to respond to treatment as well as if you get it right away. So you might need to give the patient a form that they can get migraine medication given to them at school. The other important thing is that they should not get migraine medication more than 3 times a week. This may actually cause medication overuse headache. And a headache that occurs greater than 3 times a week is a chronic headache and is treated differently in a different category. The first step is just ibuprofen or acetaminophen, using a dose appropriate for weight. Addition of caffeine may be helpful. I have one mom who used to give her 4-year-old some espresso when she got a migraine. And note that in adults, the American Academy of Neurology recommends early use of migraine-specific meds, which are triptans. Triptans can be used in teenagers, but not so much in children. Triptans are expensive and often not covered by insurance until you can prove that the child needs them. Like ibuprofen, you can't give them more than 3 times a week. Like ibuprofen, the patient needs to use them early in headache. Combined with ibuprofen or acetaminophen may work better, either in the same medication, which is Trexamet, or ibuprofen plus a triptan in 2 different doses. So these are some triptans that are approved in different ages. Sumatriptan naproxen combination is age 12 and over. Somatriptan nasal spray is age 12 and older. Rizatriptan you can use down to age 6. Almotriptan is age 12 and older. So it's not like you can have one medication that you use all the time. It obviously depends on age. Somatriptan, actually, I think in the interest of time, I will skip this, but it will be in the slides that you can have access to. Another important thing is that nausea and vomiting needs to be addressed too. In some children, especially younger children, this may be all they need. So I usually use ondansetron. It has serotonergic properties. It's good for nausea and vomiting. And there are orally disintegrating tablets, 4 milligrams and 8 milligrams, so the person does not need to be able to swallow them. Also, if they're throwing up, this might be helpful. There are generics available for that. And then other ones that also work, depending on what ones you feel comfortable with, Phenergan, Compazine, metoclopramide. If you need more aggressive therapy, you can rest medication for a prolonged headache. I will add Benadryl and Phenergan to basically allow them to sleep for a day or two. This is usually my last step before I send them to the emergency room. And then in our ED protocol, which we worked with our ED to develop, we use a cocktail that does not have narcotics, but has an antiemetic, an antihistamine, and anti-inflammatory. And as much as I would like to specify exactly which ones to use, the ER docs have ones that they like to pick. Occasionally, we will do an admission for IV dihydroergotamine, and that's an admission for a few days, and that costs a lot of money, up to $7,500. However, during that stay in the hospital, I can also often get behavioral health involved, which might be helpful for some children and adolescents. Preventive medications. Studies show that preventive medications are underprescribed, although we don't have great evidence in children and adolescents. Preventive medications may prevent chronification of headache, and consider preventive meds when headaches get to be 3 days a month or more. Most of these take 4 to 8 weeks to work, and you really have to warn them about that before they start, because otherwise the families will give it for a couple of days and then say, no, it's not working, let's stop. There is good evidence in adults. So there are many different preventive medications, magnesium, topiramate, amitriptyline, propranolol, valproic acid, which I try to stay away from because it can has potential problems with the liver. For older adolescents, the CGRP inhibitors, although we've had a great deal of problems getting insurance to cover them. They're very expensive. And then there are doses in here that you can refer to. Cyproheptadine I might use in very young children, like a 3 to a 5-year-old. Weight gain can be a real problem. And although it causes sleepiness, we give it only at night, so that's not usually a problem. If I give amitriptyline as a preventive medication, I will do an EKG to make sure everything is fine. There are a lot of side effects with this medication that will often make the person want to stop it. There's a combination of vitamins called Mig Relief that some families swear by and might be worth trying, or melatonin. Then I put these newer medications in here for you, but again, we're having a hard time getting insurance to pay for them. GPANs, as they're called, are calcitonin gene-related peptide inhibitors. They work by blocking the receptors. They can be used both for acute and preventive migraine treatment. There are many different kinds, and these are oral medications, so that's nice. CGRP monoclonal antibodies block the CGRP gene-related protein pathway, so in the same area, but by a different mechanism, and these are injectable. We have not had really, I think, any of these prescribed for anyone under 16 or under. Then there's others, lasmiditan, it's a new medication, it's a serotonin receptor agonist, and then dihydroergotamine has been released as a nasal spray, and there's a new nasal spray, zavegepant, that might be worth trying. So often patients that come in with headache, instead of having just migraine, have chronic daily headache. and chronic daily headache is described as having it 15 or more days a month. It's thought to be a complication of migraine. It transforms migraine, often from medication overuse, or it can come from tension headaches. These headaches no longer are really like migraine headaches. The pain is not severe. They might not have nausea. They might not have unilaterality, but they're just headaches every day. We see chronic pain in 1 out of 3 adults. It's a real problem. So again, asking to do early treatment for migraine to prevent chronification. Chronic pain is defined as pain that ceases to be symptomatic of the initial cause and becomes an entirely separate condition. For chronic daily headache, you really need to get a lot more treatment options. There's medication, behavioral health is important, integrative medicine is important, or both. Cognitive behavioral therapy has been shown to help with chronic daily headaches. And we will start doing some behavioral health even in our clinic. We use screening questionnaires looking for mental health disorders, looking for barriers to getting better. And as I told you, we do have a behavioral health specialist who can take on all this in clinic. This is a link to the PEDS MIDAS tool for assessing how much migraines are disabling the person, and is helpful in chronic daily headaches. And this is just an example. So if a patient is missing many full days of school, their disability assessment goes up. How many days were you not able to participate in other activities because of a headache? And this is a good tool for tracking over time as you have these patients come back in to see you. Probably these patients, unless you have a lot of time to visit with them, are best managed by a neurologist or a rehab specialist. In addition to things like amitriptyline and topiramate, we will do botulinum toxin injections, which are given about every 3 months and require injections all over the skull. Neurostimulators are also sometimes prescribed. Botulinum A toxin is the only approved medication for chronic daily headache. Insurance usually requires trials of other preventive therapies first, and you have to be over 15 years of age. Usually given in a series of 3 months apart, generally at least 2 series before relief, 31 injection sites with the most common side effect, neck pain. And many adolescents cannot do this because it's needles into their skin without being sedated, which really raises the price of doing this procedure. Stimulators, the most common is cephally. These have only been pretty recently, maybe over the last 10 years, approved in the US, and it's unclear if insurance will pay, and there are differences between insurance plans. It stimulates the trigeminal nerve, and it's kind of like the vagal nerve stimulator for epilepsy. You can get them from Amazon.com, and there are some implantable devices that people are starting to use. So if you get for chronic daily headache, behavioral health, plus CBT, cognitive behavioral therapy, patients do better than just with medication alone. You also have to look for anxiety, depression, and sleep disorders. You need to get them back to school and try not to let them miss school. And then perhaps get an education consult so they can get caught up again to where they were before. Any family and social issues that are present need to be addressed, and also try other things like the acupuncture, integrative medicine, biofeedback, psychology, psychiatry, and social work is needed. And occasionally we have to do admissions to rehab to work with these kids. During the pandemic, I saw many children and adolescents with headache by telehealth. And boy, I had some real eye-openers. I spoke to one young woman who was sitting on the edge of the bed with her mom while her mom's boyfriend was lying in the bed without a shirt on, trying to listen to a headphones. I'm not sure what he was listening to. And I just thought, oh, there are so many things wrong with this picture, and that it was going to be difficult for me to address those, especially by telehealth. Another one, the child was in the back of the car. The mom was driving and wanted me to talked to the child on the phone, and the mom had to be somewhere. And I just realized that in this family, it was really difficult for this child to get the kind of treatment they were going to need. Then there is a significant overlap, especially in chronic daily headache with migraine and tension headaches. And you, as primary care providers, most of you, I believe, might see more of these in the clinic than I do in peds neurology. Tension type headaches can also be primary or secondary to an underlying disorder, and they're more common in life, although not in my office. So criteria for tension type headaches include you have to have at least 10 episodes lasting 30 minutes to 7 days. These are typically bilateral. They're non-pulsating, mild to moderate intensity, not aggravated by routine physical activity, and that you can't have nausea and vomiting. You can have either photo or phonophobia, but not both. And again, these are just the criteria established by the International Headache Foundation. So ibuprofen and acetaminophen are, again, what I use to treat these people. Caffeine may help. Some people think triptans help. There's not good evidence. Avoiding narcotics is really important. And preventive treatments may help and are probably worth a try. I want to briefly touch on childhood periodic syndromes, which we think are a type of migraine headache. One of these is cyclical vomiting, where episodes of nausea and vomiting last a few days. Otherwise, the child is normal. These children will often go to GI first, and then they will sometimes send them to you because they can't find anything wrong in terms of gastrointestinal problems. So then they get sent to neurology. Then there's an entity called abdominal migraine, where patients have episodes of abdominal pain without physical explanation. Again, these might sometimes come to you from GI because they can't figure anything out and they think it might be migraine. Unbelievably, these actually do sometimes respond to preventive medications that we use for migraine. There's also an entity, benign paroxysmal vertigo of childhood, with children having episodes of vertigo that come and go that sometimes respond to migraine medications. Colic is also, we think, a migraine equivalent. It is found more in families where migraines exist, and we don't usually treat with preventive medications, of course, but we do see this more in families where a grandmother, an aunt, a mom, all have migraine. So then I want to talk about a different kind of headache that we do see in the emergency room, or worry that we are seeing in the emergency room. So what if the patient that comes in is an overweight young lady with a BMI of 29. She tells you she has many floaters in her vision. She's on minocycline for acne, and she may have some peripheral vision loss when you do the eye exam. So this is the disc that you see when you do a fundoscopic exam. It's nice and clear, it's defined. You can see where the blood vessels are coming from, whereas this is a disc with papilledema. And you can see that there's a bulge in the optic disc. This is really hard to see. I am astounded that we have been doing this on our own in an office in children that don't stay still very well. And the people misdiagnosing papilledema, even in emergency rooms, has led to many lumbar punctures that were unneeded. And I was referring to this a little bit earlier, but now in our ER and in many ERs, you can take a fundoscopic picture, which you can do without even dilating the child's eyes, and that is digitally sent to an ophthalmologist or optometrist who can immediately give you an answer on whether there's papilledema or not, and then you can avoid the LP. So what I'm talking about, of course, is pseudotumor cerebri, or idiopathic intracranial hypertension. It can be secondary to a lot of conditions, including a venous sinus thrombosis, medications with minocycline being one of the top ones, other medical conditions. You need the papilledema and MRI changes for a diagnosis, and it's not helpful to do an LP for increased pressure if an ophthalmologic exam and MRIs are normal. So the scenario will be that the young woman that is overweight comes in, is on minocycline. Nobody can really tell whether she has papilledema or not. She gets an LP. Then when she gets the LP, she has a post-spinal tap headache, and then she's in the hospital for a couple of days. And at that time, an ophthalmologist comes by and sees her and says that she doesn't have a papilledema anyway. There are truly people with pseudotumor cerebri. It will just be nice to prevent hospitalizations for people that don't really have that. Finally, I want to talk about the summary that treatment of headaches can be very difficult, and you just have to get these patients back in again. You need to stick with the family. It's trial and error. And sometimes I'm seeing these kids for over 5 years. Sometimes they will go for a year or so without coming in, but then when things change in their lives, they'll come back again. I'd like to make a push for children not being allowed to miss school and to get them back in as soon as possible if they've come to you where they have not been going to school. And that for difficult headaches, integrative medicine for things like acupuncture, behavioral health for cognitive behavioral therapy, and looking for and treating with psychiatry as necessary underlying conditions such as anxiety and depression. And I am done. I guess I really talked way too fast.
No, I think you did great. Thank you so much, Dr. Kerr. We do have questions. So I'm going to just ask them. We may have talked through some of them already, but still ask. Could you talk about your approach to headaches with exertion? Should we refer to neuro for workup? And please disregard if we are going to address.
And please, what? Oh,
Disregard if we already addressed.
yeah, the main thing I do for headache with exertion is that raises my degree of concern that there's an underlying condition. And I will get an EKG and an MRI, basically. I might also do labs in that condition, but I have to say that I don't think I've ever had any labs that I've done give me an answer. But it mostly makes it that I'm going to get an MRI.
Okay. I gave up on the fundoscopic exam a long time ago. Is it worth even trying to perfect this skill with the typical outpatient exam equipment?
So I agree. I think that we've been fooling ourselves in outpatient for years and years, thinking that we really know what we're doing. Even the neurosurgeons in our hospital will send patients to ophthalmology. And I know if a patient doesn't have insurance, it's impossible to do this. But it's also perhaps an optometrist would be something that could be done. And then also I talked about the way that they can do those pictures in the emergency room with a non-dilated eye exam, a quick fundoscopic camera, and being sent out to an ophthalmologist. And if that can be, if you can figure out where to do that locally, that might be a good way to do it if you're worried.
What was the age for Botox?
16 is the age for Botox. 16, maybe 17. But insurance has sometimes allowed us to go a lot farther down than that with a child that we've been working with for years. But it's one of those things that you have to contact the insurance company and then they say no, and then you have to talk to a doctor at the insurance company. And again, almost all the adolescents need sedation for that or think they need sedation for that. So it becomes a much more expensive procedure than it has to be.
Okay. If an aura is infrequent, does any history of aura even once mean no OCPs for contraception?
Yeah, that nobody really knows the answer well to that, including docs that I have sent, docs in OB-GYN, which I've sent patients to. The data is really confusing. Many patients with aura, I'm not sure whether it matters whether it's frequent or infrequent. So I think we're just talking about whether people have aura at all. The data do not show a difference if they have, 20 auras a year or one a year. And it may increase the risk for stroke a little bit, but also contraception is really important. So it's one of those, perhaps yes, perhaps no. You might think about using an IUD or something similar instead of using birth control pills. And a birth control with estrogen only and not progesterone seems to be a little better, but it's a thorny question. The auras are really interesting. We have a pediatric orthopedic surgeon that has had 2 auras in his life. And he told me about the first one, and it was really dramatic. I don't remember all the details, but then there was a time that he had an aura in the emergency room, got completely confused, was found wandering in the hallway looking for the patient he was going to operate on. And he was telling me this story, and I said, yeah, it's one of your auras, remember? And he hadn't put it together with auras. So it's almost easier to have more auras because they're kind of scary. And if you have more, you recognize them sooner. So just a quick story about an infrequent aura.
Thank you. Has there been an uptick in tension migraine issues with the increased use of screen time or computer? Once you start a patient on a treatment course, what is your continuity of care approach? As in, what kind of follow-up do you establish?
So there is definitely an uptake in all kinds of headache with so much screen time. For a while, people were using blue lenses, and that was really exciting. And there's still a lot of people that use blue lenses, but the latest data I've shown is that they can't really prove that there is a change for the good if you use blue lenses. But that's not to say that there aren't subtypes that the studies have not found that would respond to blue lenses. So it's worth a try. And then what was the other part? Let's see. Oh, if somebody has a migraine once in a while, and I'm not even going to do a preventative, that would probably be like a 6-month return. If I'm starting them on a preventive, I usually see them probably in about a month, which is about as soon as I can get follow-ups into my calendar. What I'm hopefully not doing is putting them on a medication that they stop in 3 days because I don't like the way it makes them feel, and then I lose them to follow-up. So I think it's really important to put in some kind of follow-up to kind of remind me if I will get a notice that they don't come to that follow-up and can go on with the patient. If I have a patient with chronic daily headaches, I am seeing them frequently. Often a couple of times in a row, I will try to see them every 2 or 3 weeks. Those are quick appointments, but I really find that if I see them often, it will help. And some of that, sometimes I think it's just cheerleading for that patient. I don't know. I change their medication. I look at their diet. I make sure they're drinking water. I check in their sleep. With patients like that, also, I have to work with the school or a social worker. If I have one available, we'll work with the school because those kids are often having lots of problems in school that are making their headaches worse.
Rebound headaches, is it more likely depending on number of days a month or week? I'm sorry, I thought rebound headaches is more likely depending on number of days a month, not a week.
Where is that one?
In the Q&A, it's the first at the top.
Okay. So tell me that one again.
I thought rebound headache is more likely depending on number of days a month and not a week.
Oh, yeah, I think that's true in general. If somebody has a rebound headache and it's only one time in a week, it's not as important as if it's happening many times a month. I hope that answers. I'm not sure.
Which triptan and mode of delivery works best for adolescents and any different for children?
Oh, here's one. I think that's to do with the same question, 3 times a week is a limit for pain medication. Yes, once we see 3 headaches a week, we worry that that is going to start chronification and turning into a chronic daily headache. So at 3 times a week, whether they're rebounding or not, I will often start a preventive medication or cognitive behavioral therapy or something like that. So 3 times a week is a red flag for me. And I'm sorry, Kristen, one more time.
New question was, and I'm going to mess up the medication name, which tryptan and mode of delivery works best for adolescents and any different for children?
So you are very, I have to be very guided by what triptans I use, by what it tells me. So almatriptan, for instance, I can use down to age 6. Others are not approved for until age 12. Others aren't approved until age 16. So I look at what age I have a child, and then I go from there. So I use a different one with kids age 6 than I would age 12. And then oral or nasal spray. Adolescents do not typically want to try any injectables, although if they've had the headaches for a long time, they might have gotten to that point. So that's how I choose.
And I think I just heard you say this, but do pediatric patients get vestibular migraines?
It's very rare, but yes, they sometimes will.
Okay.
So there's a comment about valproic acid in there. Yeah, I don't use valproic acid very much unless I am really, really, really pushed against the wall. I would worry about, especially in females with the problems about pregnancy. There's a little bit of a concern about liver problems, but that's really probably incredibly rare and only with kids that have underlying metabolic disease. But I'd be more likely to use it in a boy.
Okay, next question. Caffeine is always recommended as a drink and not Excedrin?
It's just kind of one of those things that you pick however you like to do it. I thought the mom giving her 4-year-old espresso was a little strange, but the child did not like to or couldn't really swallow pills. So she did the coffee and then she did a liquid ibuprofen, but Excedrin is fine. And some people really respond to caffeine. And some patients, when they come in, they know well what they respond to. So I really try to listen to what they're telling me when they come in.
So just clarifying, every patient with persistent headache we should send out for a fundoscopic exam if insurance covers?
No. There was somebody in here that recommended a panoptic. We just didn't have those available in clinics. So if you can do that. No, my comments about ophthalmoscopes were more intended for if you have a kid in the ER that you're worrying about papilledema and hypertension, intracranial hypertension.
Do magnesium and B2 help tension or chronic daily headaches?
So there is mixed evidence of that. There is no one medication. However, if you talk to families that use that and think it works, I don't know if there are subsets, but again, worth trying. So that's one reason why you have to see these kids over and over. You're going to try one thing one time. If that doesn't work, try another thing. And in truth, I don't know all the time whether I am actually making them feel better or whether their headache is cycling up or down. And I'm going through a better time for their headaches. But I think the important thing is to stick with the family.
Great. I don't see any other questions right now, but we'll pause. We still have a few minutes. This is not my email address. I'm going to type my email address into the chat. For anybody that's sitting on a webinar, like in the conference room or on somebody else's screen, if you could just send me your name, I'll make sure our attendee list is updated and that you get the resources, including the CME survey. This CME survey needs to be completed with correct date and speaker, May 20th, Dr. Lynn Kerr. And you'll get CME credit as soon as you complete that. We have a great talk. Thanks, Dr. Kerr. I agree. This was fantastic.
Thank you, Dr. Williams.
And last question, I think maybe the last, but right now, any common mistakes we make to avoid?
So we've looked at the number of MRIs ordered by doctors in our emergency room and neurologists, not so much primary care providers, but there are a few doctors that always really stick out. So out of the 20 docs in the emergency room, there's one guy that, or one woman that orders an MRI on every single kid that comes in, or often a CT in the emergency room. And those are unnecessary. So that's one kind of mistake, is over evaluating for things that just don't need evaluating. And then, of course, there's the other mistake of not recognizing that there is something like a brain tumor going on and missing that. So one of the things that I'm sure that you all do, I learned to do early on is, you say to the patient, let's try this, but if things are getting worse, call me or come back. This might not be the answer, but come back. So in a patient who is having headaches that are just starting, but then on that timeline is having this acute chronically progressive headache, that you will keep being available for that person.
Can iron deficiency with or without anemia cause headaches?
Oh, who knows? People have looked at that, but not all people that have iron deficiency have headaches. And so probably in a child that is already predisposed to migraine from having a genetic family history, and that gene usually goes through women, they might be more likely to get a migraine with iron deficiency.
And I just want to remind everyone, if you are logged into Zoom right now, so you see your name on the participant list, you're logged in, you will get the CME survey link that'll deploy right after this webinar in a tab on your browser. And you'll also get an email tomorrow, 24 hours from now, with the CME survey link and the slide deck. So if you are logged in, you're in your name, you don't have to worry about emailing me or letting me know. It's for those of you that are not logged in and joining on your friend's computer that I need to know that person. All right. Well, I don't see any more questions. Thank you so much, Dr. Kerr. This was fantastic. And thank you all for joining us today.
Hi, thank you guys.
Oh, one more question. I'm so sorry, Dr. Williams. Any suggestions or experience or data with vitamin D levels?
If I'm going to start vitamin D, I will usually get a level. And again, it's one of those things that might or might not help. There's evidence in some children that it's helpful. It doesn't really seem to be linked to whether their vitamin D level is low. It just helps with some people. So, again, it's one of those things worth trying.
Great. Thank you so much. Everybody seems to really enjoy this session, so thank you, Dr. Kerr. And I'm really going to hit stop for time this time, so have a great day, everybody.